Good afternoon and welcome to today's Public Health Ontario Rounds presentation on inflicted injuries among children and youth during the pandemic, a study across 2 Canadian provinces. My name is Brendan Smith. I'm a scientist in health promotion, chronic disease, and injury prevention at Public Health Ontario, and I have the pleasure of moderating today's session. As the moderator of the session, I do not have any conflicts of interest. To begin today's session, we wish to acknowledge this land on which Public Health Ontario operates, which has been the traditional land of many distinct nations, including the Huron-Wendat, the Seneca, Métis, Haudenosaunee, and Anishinaabe, specifically recognizing Treaty 13 signed by the Mississaugas of the Credit First Nation. Today, this meeting place is still the home to many diverse Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this land. I am now pleased to introduce today's speakers, Dr. Sarah Richmond and Dr. Ian Pike. Dr. Sarah Richmond is the Injury Prevention Lead in Health Promotion at Public Health Ontario and an Assistant Professor of Epidemiology at the Dalla Lana School of Public Health, University of Toronto. With expertise in injury epidemiology, implementation science, and knowledge translation, Dr. Richmond's background as an injury epidemiologist and certified exercise physiologist guides her work in advancing injury prevention research and its real-world applications. Dr. Ian Pike is an investigator with the British Columbia Injury Research and Prevention Unit and a professor of pediatrics at the University of British Columbia. In addition to his academic roles, he co-leads the Evidence to Innovation theme at BC Children's Hospital Research Institute, serves as the scientific director of the Community Against Preventable Injuries, and is a board member for Parachute. Over his career, Dr. Pike has co-led national research teams addressing essential areas in injury prevention, including the development of injury indicators for Canadian children and youth, initiatives to improving safety among First Nations and Inuit children, child passenger safety, and the impact of risky play. His work also explores the effectiveness of social marketing in reducing preventable injuries, with his current research focusing on social and systems innovations to further prevent these risks. With that, I'd like to start the presentation by passing it off to Dr. Richmond.
Thank you so much, Brendan, and thank you all for joining us today for a presentation that Dr. Pike and I are very pleased to deliver, as well as think is very important to discuss, and that's inflicted injuries among children and youth during the pandemic. So we'd like to start this presentation by disclaiming that the authors of this work have no conflict of interest to report. So as we all know, the COVID-19 pandemic was marked by an unprecedented period of stay-at-home policies, sustained school closures, disruptions to both community and recreational service use. We all shifted to remote work. And generally, as a population, we were avoiding attending hospital due to fear of COVID-19 infection. Although these measures aim to reduce the community virus transmission and alleviate the burden on hospitals in Canada, there may have been some indirect effects on other health outcomes. One of those really important health outcomes is inflicted violence in children and youth. The literature tells us that COVID-19 policies increase social isolation, they increase the stress among families, there was economic loss, as well as very significant social service reductions. This led to concerns across the country regarding an increased risk for inflicted violence and child maltreatment. We were hearing in the early days of COVID that there was an uptick in the number of reported violent incidents, as well as sexual assaults both in Ontario and British Columbia. For example, through social media, we heard from PHO, or the Children's Hospital of Eastern Ontario, that there was an increase not only in the number of violent incidents, but increase in the severity of incidents seen during the early days of the pandemic. We had also heard from Kids Help Phone in British Columbia that there was a 70% increase in the number of phone calls and a 51% increase in text messages from children and youth in the early days of the pandemic. We also learned that the pandemic had a disproportionate impact on children and youth, as well as people of lower socioeconomic status. Some of you may have heard that the WHO has called violence-related incidents involving children the hidden crisis of the pandemic. However, at the same time, we were learning from reports such as the Children First Canada report that was published in 2020 that there were no data specific to the effects of COVID-19 policies on inflicted injuries in children and youth. So the aim of this study broadly was to look at violence and inflicted violence and child maltreatment in our children and youth in Ontario and British Columbia. We define child maltreatment by the WHO as the abuse or neglect of children and youth, generally under the age of 18, and includes physical abuse, sexual abuse, emotional abuse, neglect, as well as exposure to family violence. We know at baseline that these injuries are high. They are too high for our children and youth. In this report from Statistics Canada in Ontario, over 64% of people in Ontario reported some form of inflicted violence before the age of 15. There were over 7,000 cases of physical abuse, 1,000 cases of sexual abuse, 8,000 cases of neglect, and over 17,000 reports of exposure to intimate partner violence. We're seeing the same numbers, even higher numbers in British Columbia, with over 69% of people in BC reporting some form of inflicted violence. Of those reports, over 28% report both physical and non-physical forms of violence. And why this is important is because we know that there are long-term adverse outcomes related to child maltreatment, and that includes cognitive disability, anxiety, depression, addiction disorder, obesity, and cardiovascular disease, to name a few. So the objective of our work was to investigate what is reported on inflicted violence injuries among children and youth during the pandemic from the scientific literature, to investigate inflicted violence injuries among children and youth in both provinces, so Ontario and British Columbia, using health administrative data during the pandemic and comparing this data to previous to the pandemic. We wanted to describe and better understand the context of these injuries, again, comparing what we knew was happening during the pandemic to previous to the pandemic, and then to really sort of elucidate one type of child maltreatment and to look at whether or not that form of child maltreatment changed during the pandemic. So the first study we completed was an umbrella review, and this was, of course, on inflicted violence and injury in children and youth. So we started by doing a scoping review, and that was conducted by PHO in 2022. We found at the time there was over 2,000 studies that had been published since 2020 that assessed the impact of COVID-19 policies on child abuse and maltreatment outcomes that included physical, emotional, sexual abuse, as well as neglect. And generally, the scoping review found that there was three categories of studies, or three categories of data in which these studies reported on. The first was health administrative data, so our emergency room, emergency department visits and hospitalizations. There were police or child protective services data, and survey or other crowdsourcing data. So from the results of this scoping review, we decided to complete an umbrella review. At the time, reviewing the amount of literature in 2022, there were enough systematic reviews to warrant conducting an umbrella review. So the aim of this study was to study the impact of COVID-19 policies on child abuse and neglect, and as well as to review what the authors had made as recommendations toward future work in this area. So we completed a systematic search of articles across 5 databases that included Medline, Embase, PsycInfo, SocIndex, and CINAHL between the dates of March 2022 and April 24th of 2023. 3 reviewers independently screened and reviewed titles, as well as abstracts for study inclusion. We completed hand searches of the reference list of the included studies, and we also conducted expert consultation with project team members to acquire any additional data sources. Review level studies were included if they examined any abuse or neglect-related outcomes in children and youth, or the parents of children and youth under the age of 18, and were published in the English language. We excluded studies that were published previous to 2020 that did not include data during the pandemic, or had a study population of adults without children, or focused on other forms of adversity. We completed a quality appraisal of each of the included articles using the Health Evidence Quality Appraisal tool and categorized findings by what we found in the scoping review, those categories of data, administrative data sources, survey data sources, or other data sources. We also narratively summarized the reported recommendations of the authors. So this figure describes the number of studies that were searched and screened for this review. There were a total of 1,422 articles that were screened for inclusion, 182 reviewed in full text, and a final 11 studies that were included in the umbrella review. 6 studies were systematic reviews, 2 were narrative reviews, 2 were rapid systematic reviews, and 1 was a scoping review. 8 of the included reviews examined child abuse and neglect outcomes explicitly, while 3 reviews included multiple outcomes of child health and well-being. So as I mentioned, in total, 11 reviews were included. 2 reviews are of strong quality, 7 were of moderate quality, and 2 were weak. Overall, studies within the reviews that reported from administrative data sources demonstrated overall decreases in child abuse and neglect outcomes when looking at data during the pandemic compared to previous to the pandemic. When looking at studies using cross-sectional data, all studies but one that were included in this review reported increases. Interestingly, when we were examining the data by types of abuse, overall there were reported increases in emotional abuse, neglect, as well as psychological abuse, and decreases in cases of physical and sexual abuse. What this told us was that we needed to access or potentially access other data sources other than just health administrative data to understand what was really happening during the pandemic. So after synthesizing these 11 reviews, the answer to whether or not the COVID-19 lockdown period increased child abuse and neglect remained uncertain. So child abuse either increased or decreased depending on the data source. Empirical evidence showed a clear decrease in health and social service administrative outcomes, such as ED visits or case openings, so child protective service case openings. However, this was explained by an overall decrease in attendance to hospitals. So people were avoiding attending hospital during the early days of the COVID-19 pandemic in fear of infection. Evidence using survey data showed that families were in heightened distress during the pandemic and had an increased prevalence or reporting of harsh parenting practices. Authors from these systematic reviews recommended that future work should enhance data collection methods as well as surveillance for reporting of inflicted violence injuries in children and youth, as well as to focus on intervention during public health emergencies, where those traditional mechanisms in which we collect data, often in schools or often in ED centers across the country, are limited. They also recommended an increase in focus on the rigor of reporting of these studies. So this umbrella review included all types of studies, all types of reviews, pardon me, which captures a variety of data sources, as well as provides a broad perspective on the impact of COVID on the occurrence of child abuse and neglect. We included a very comprehensive and systematic search strategy, as well as screening, and included a very rigorous quality appraisal process. Some of the limitations for this work include that the majority of studies that were included in this review are of moderate quality, 2, of course, were of weak. And the lion's share of the studies that were included in each of the reviews had a short time period into the pandemic, which may increase the risk of bias. Of course, there's limitations around the generalizability of these studies to Ontario and British Columbia populations, particularly when we think of the varying policies that were in place at the time, particularly comparing Ontario to British Columbia. And of course, there is some sensitivity around our ability to collect violence-related outcomes in these hospital administrative data sources. So I'm just going to hand it over to Ian now to discuss Project 2. So in this study, we looked at our health administrative data, both in Ontario and British Columbia, and wanted to look at the rates of inflicted violence in children and youth.
Thank you, Sarah. So Sarah has mentioned that early in the pandemic, there were anecdotal and even media reports indicating an increase in the number of inflicted violence-related injuries among children and youth. And so the objective of this study was to use administrative data to investigate whether inflicted violence-related injuries among children and youth were associated with COVID-19 stay-at-home policies. And we were able to attract data for both Ontario and British Columbia, such that we had an extensive pre-pandemic period and then could follow cases post-pandemic, or from the start of the pandemic in April 2020, for about 24 months. So next. As I noted, administrative data were available for both provinces for the period April 1, 2015 to March 31st, 2022. Those data were available for all children and youth 0 to 19 years of age, and we extracted data from those administrative sets if the ICD-10 codes were X85 to Y09, which includes all inflicted violence codes or assault codes, and those include physical assault, sexual assault, neglect and abandonment, and other forms of maltreatment. It needs to be noted here, though, for Ontario, data were available for both emergency department presentations and hospital separations. In British Columbia, the data was restricted to hospital separations only due to the limitations in the version of the National Ambulatory Care Reporting System, or NACRS, that's implemented in BC. Regrettably, in British Columbia, it's not implemented province-wide. And of all of the hospitals and emergency departments, there are only 30 hospitals throughout the province that report to the NACRS system. And secondly, the bigger limitation is that the version that's implemented in British Columbia is called NACRS Level 2, that does not provide the external cause of injury. And while you can see the type of injury, which may provide clues to whether it was an inflicted violence-related injury, the coding for the external type of injury, which would be included in the X85 to Y09 codes, is not. So move next slide, please. So the timeline, the periods as noted, were from April 1st, 2015 to March 2022, and we defined the pre-COVID period for 60 months from April 1st, 2015 to March 2020. The COVID period commenced April 1st, 2020 for the purposes of analysis and went on for 24 months until March 2022. We were able to categorize our data according to sex and age groups. And due to smaller numbers in the lower age groups, 0 to 9-year-olds were grouped and include both male and female. However, in the older youth, 10 to 19, we were able to group by male and separately by female sex. In terms of linking data to deprivation, because we were interested to see whether inflicted and violence-related injuries were associated at all with levels of deprivation, we utilized both the ON-MARG and the CAN-MARG indices, which provide data according to deprivation quintile, one being the least deprived and 5 being the most deprived quintiles. Next slide, please. So we utilized an interrupted time series design to model the change in monthly violence-related hospitalizations before and during the pandemic. And the interruption point here was at April 2020. We used the negative binomial models to estimate the immediate effect of the COVID-19 policy and the change in number of injuries during the pandemic. In the Ontario data, the Ontario data was sufficient in its numbers to be aggregated by month. But because of smaller numbers and for the purposes of more meaningful analysis, the BC data was aggregated by quarters or 3-month periods. Next slide, please. So these are the results, and the panels here are a little busy, but these are the results from Ontario. On the right-hand side, you see the chart, the top right for emergency department visits. For the bottom right, the panels are related to the hospitalizations or the hospital separations. So after adjusting for seasonality and population changes over the study period, in Ontario, we observed a 56% decrease in violence-related emergency department visits and a 35% decrease in hospitalizations immediately after the implementation of the pandemic policy. So it seems at the time that stay-at-home policies were implemented, there was a drastic reduction in both hospital separations and emergency department visits in Ontario. This was then followed by moderate increasing trends over the following 24 months that approached pre-pandemic levels by the end of that period. We observed no difference in the effect of the pandemic policies on the rate of violence-related emergency department visits and hospitalizations by either sex or age. However, as you can see in the panels, males aged 10 to 19 had a higher average rate of injuries compared to females, which is the middle line, as well as those in the younger age group, which is the green line at the bottom of the charts. And this gradient existed pre-pandemic and post-pandemic during the increasing trends. Next slide, please. This represents the same information from British Columbia. Recall, however, that this line appears much smoother because of the averaging over the quarters rather than monthly. The start of the pandemic at the same time did not exhibit the same dramatic reduction associated with the implementation of stay-at-home policies. And we're still trying to understand why that might be. At this current time, we don't have an explanation for why there was a dramatic decrease in Ontario that was not evident in British Columbia. However, we see the same gradients where males aged 10 to 19 in British Columbia had higher average rates of injuries compared to females, as well as those in younger age groups over the entire study period. Next slide, please, Sarah. When we examined the injury rates by level of marginalization, we observed no difference in the effect of the pandemic policies on the rate of violence-related emergency department and hospitalization levels in related to deprivation. And this is the chart from Ontario. And in this chart, both hospitalizations and emergency department visits have been grouped for the purposes of the analysis. However, what we do see is that those in the most deprived areas had higher average rates of injuries compared to those in the least deprived areas over the entire study period. And I would add that this is a common observation in injury data, where we see a clear gradient of increasing injury with increasing deprivation. And you can see here the separation and gradient with the purple line at the top representing those in the most deprived neighborhoods, with the darker blue line at the bottom being the least deprived neighborhoods, and the gradient across. And this gradient exists both before and after the interruption and start of the pandemic, and the increasing trends back to normal over the period of 24 months following that interruption period. Next slide, please, Sarah. Again, the data from British Columbia shows no dramatic reductions at the period of the start of the pandemic. And like Ontario, the story in BC is similar, with a clear gradient of inflicted violence-related injury increasing with increased deprivation across the study period. Next slide, please, Sarah. So to summarize, we observed an abrupt decrease in the rate of violence-related emergency department visits and hospital separations immediately after the onset of the pandemic policies in Ontario. However, this same decrease was not observed in British Columbia. Following this, violence-related injuries increased in both provinces and approached pre-pandemic levels after the 24-month period in our study. At baseline for both provinces, inflicted injuries were higher in older males over females and in areas of higher marginalization. So the next slide will then just look at some of the strengths and limitations associated with this particular analysis. As far as we know, this is the first time to publish these data related to the particular length of time that we were able to conduct the analysis in post-interruption or post-pandemic period. Some studies were published that looked at data for 6 months following the start of the pandemic. And of course, we feel that we've added to the story by being able to look at data out as far as 24 months post-pandemic. This is the first time as well that we have been able to link data for that period to the levels of marginalization to try and look at the relationship between inflicted injury and deprivation, and whether there was any relationship between marginalization and the COVID-19 policies. In general, there's a bit of a dearth of information on violence and inflicted injuries in Canada, and we think that this study represents a strength in being able to add at least some insights on what progressed prior to and through the pandemic. However, the number of cases is relatively low in both provinces, and so analyses represents a bit of a challenge because of those low numbers and our need to group data by quarters versus months in British Columbia, and to group both sexes in the younger age group. We suffer from a lack of a control group, but we did include all violence-related ICD-10 codes, and it's important to note that these are not, in case you're thinking of parent or caregiver inflicted injury on children and youth. These codes also include peer-to-peer violence, which could be sibling, could be neighbors, etc. And like all administrative data sets, there are some limitations in using the ICD-10 codes that could have arisen from misclassification. Certainly, coders are well trained and know how to do this job, but there's always the chance that there are some misclassifications when they convert from the medical charts. And so I'll now pass it back to Sarah to discuss the third project in this study, which was about accessing new data sources to better understand the changes in child maltreatment.
Thank you so much, Ian. So the objectives of this work, as Ian mentioned, was to access alternative data sources or an additional data source that might help us to understand the circumstances surrounding injuries that were happening during the pandemic compared to previous to the pandemic. And of course, as the project has set out, is to think about these cases within Ontario and make those comparisons to those cases in British Columbia. So data for this study comes from the Canadian Hospital Injury Reporting and Prevention Program, also known as CHIRP, which is a sentinel surveillance system in Canada that collects data on all patients with injuries who present to an emergency department of the 20 participating hospitals across Canada. The CHIRP datasets includes a narrative component that is sort of the unique part of this data source that provides us some additional information to the existing health administrative data sources that we have access to. So CHIRP, within the CHIRP format, asks the following questions. What was the injured person doing when the injury occurred? What went wrong? And where did the injury take place? So data was extracted for both Ontario and British Columbia from CHIRP in patients under the age of 18 from January 2018 to March of 2022. We conducted a content analysis of that narrative component by using a code book that was developed previously from the Public Health Agency of Canada and scanned the narrative fields and tried to contextualize these text fields into codes based on this existing code book. The variables of interest that were included in this study were maltreatment type, child protective services and police involvement, any information that was related to the perpetrator, the setting or where the injury took place, and any other risk factors that would be considered important for this analysis, including weapon use and substance use. We performed statistical analysis using R and basically just generated some descriptive statistics testing for statistical significance of during the pandemic compared to previous to the pandemic, and just looked at that data in Ontario compared to British Columbia. Cases were included if they were children and youth under the age of 18, presented to hospital with an indication of inflicted violence. And of course, that includes physical assault, sexual assault, neglect, exposure to family violence, and any other types of child maltreatment. We also included any suspected cases as cases. There was only a small number of suspected cases, and we included those in actual determined cases of child maltreatment. Inclusion criteria were those that were unintentional injuries, injuries that were self-inflicted, emotional trauma injuries, or children that presented to the emergency department for emotional trauma from previous assault without a current injury at the time of visit, and any cases where there was a lack of indication of physical or sexual assault, neglect, or non-intentional injury. So these are some of the results of the total cases of Ontario and British Columbia. So as you can see here in Ontario to your left, there were just over 2,000 cases in total. 55% of the cases were male, and the average age was about 15 years for Ontario and about 14 years in British Columbia. So in Ontario, you can see there was a decrease in the number of cases from before the pandemic to during the pandemic of just over 1,000 cases previous to just over 900 cases during the pandemic. In BC, we see a smaller number of cases, of course. We have a smaller population in British Columbia with a total number of cases of 536, with cases increasing from 162 cases to 180 cases during the pandemic. Looking at Ontario here, and this is Ontario data presented to you on the left side of your screen of physical assault and sexual assault cases when we looked at child maltreatment type. You can see here there was a decrease in the overall number of cases of physical assault before the pandemic to during the pandemic. Interestingly, we saw an increase in the number of reported sexual assault cases from 167 cases to just over 190 cases. Other child maltreatment type cases made up a very small amount of cases and were not included in this in the data presented here. When we looked at the data in British Columbia, there were no significant changes in the number of cases from during the pandemic to compared to previous to the pandemic. When looking at the setting of child maltreatment cases, we can see similar changes across both provinces. Here you can see there was a decrease in both community and school settings, so on the left and right side of each of those figures, but there was an increase in the number of inflicted violence injury cases that were happening within the home. When we look at perpetrator type, and just to make a note that these are physical assault cases by perpetrator type, there was a decrease in the number of cases that were known peer or stranger cases. However, there was an increase in cases that were reported by immediate family members or the perpetrator being immediate family members. When we look at British Columbia, there was a decrease in known peer cases from 25% to 14%. When we looked at other perpetrator types, there was no significant changes in other perpetrator types. These results are specific to sexual assault. As you can see, the figure to the left is for Ontario only. So when we look at sexual assault cases, we see a decrease in the number of immediate family members that were reported as the perpetrator. However, there was an increase in known adults that were not family members. When we look again here in British Columbia, there are no discernible differences in perpetrator type when we looked at sexual assault cases. So in summary, there was an overall change in the child maltreatment case during the pandemic. So we saw overall decreases in Ontario and increases in the total number of cases in British Columbia. And in Ontario specifically, we see a decrease in physical assault cases, but we see an increase in sexual assault cases. We also saw some changes in perpetrator type as well as in the setting where the injury occurred in Ontario. However, when we look at the BC data, there was no differences in maltreatment type. However, there was a shift from known peers as the perpetrator to immediate family members as the perpetrator type during the pandemic. So some strengths and limitations of this work is, of course, a strength of being an alternative data set that helps us to better understand the context of injury, the setting of injury, the type of child maltreatment, and it provides this unique narrative component that gives us some more information about risk factors and protective factors in this population. There are some limitations to this work. Of course, these data are not representative of the Canadian population, and there is a possibility that the narratives are not filled out in a standardized way. Of course, these type of cases are very sensitive, and the way in which we collect information in this case is very sensitive. So there's a potential to include some possible omissions in the narrative component. And of course, we believe that there is a really significant chance of an underreport of the true number of inflicted violence cases in each of the provinces. So I'm going to hand it back over to Ian to discuss a very specific type of inflicted injury, which is traumatic head injury and shaken baby syndrome in British Columbia.
Thank you, Sarah. You can move to the next slide, please. So we have the opportunity in British Columbia, because of long-standing work with child protection services, to access data specific to traumatic head injury from child maltreatment, or sometimes known as shaken baby syndrome. So the purpose of this part of the study was to determine the effects of COVID-19 policies on rates of THI in relation to how those policies were implemented, and to look at this very specific particular type of inflicted injury on young children 0 to 2 years of age, and to compare pre-pandemic levels to post-pandemic levels. We were particularly interested in looking at school closures, child care center closures, and other recreation community center closures. And during the period of pre-pandemic to the point of lockdown, and then over the period of restrictions. Next slide, please, Sarah. In order to do this, we accessed the COVID timeline information that was available through the Canadian Institutes for Health Information, or CIHI. In British Columbia, there were about 140 various public health interventions in BC during the pandemic, obviously far too many to utilize in this kind of analyses. And so we looked at three particular intervention categories that included openings and closures that I've mentioned with respect to schools, daycares, and community centers. The availability and access to health services, as well as social distancing policies. The surveillance data that we looked at was available from January 2016 to May 2022, with the pre-pandemic period being January 2016 to March 2020, and the post-pandemic period being defined as April 2020 to May 2022. So next slide, please. The data sources, as I noted, come from the Child Protection Service, which operates a data collection in British Columbia. And these data that were included in this particular analysis for traumatic head injury from child maltreatment result from a review of all physical abuse cases. And we do these reviews 3 or 4 times a year with a 6-member team. 3 members from the Child Protection Service, including the medical director, and 3 members of our BC Injury Research and Prevention Unit, including myself and other researchers with expertise in inflicted injury. That chart review results in the identification of traumatic head injury child maltreatment cases utilizing Feldman's criteria. And this is a criteria that upon chart review and reading the narratives and attending physicians' reports, we come to consensus on whether the case is definitely not a traumatic head injury from child maltreatment or a definite case, and grades in between as unknown, possible, and probable. In this analysis, we included cases that were probable and definite according to our categorization. I should note that this does not do anything to change the records within the Child Protection Services files. This is purely for the case of our surveillance of this particular type of injury. Next slide, please, Sarah. And so COVID-19 policies, as I said, were aggregated in British Columbia by month and year. In this case, we suffered from very small numbers. So the aggregation of these policies in time periods that allow for some type of analysis is important. We compared the traumatic head injury child maltreatment rates pre-COVID with post-COVID period using a Poisson regression model. Next slide, please, Sarah. This chart shows you the number of cases prior to the start of the COVID policies and those following. And while one might say, oh, looks like you're getting more cases post COVID, I can tell you that there's no discernible difference here, either statistically or average. And the next slide, please, Sarah, will point that out, that even when we use monthly counts, pre-post rate ratios show no difference, with a monthly average of 0.3 to 0.26 cases per month. And the yearly counts, again, no discernible difference, with the yearly averages being exactly the same. So neither monthly nor yearly counts were statistically significant or different. And in British Columbia, COVID-19 stay-at-home policies did not appear to have a significant impact on traumatic head injury from child maltreatment among children 0 to 2 years of age in our province. Next slide, please, Sarah. So some of the strengths and limitations associated with this particular study include the fact that we have a robust child protection services surveillance system in place, has been in place for many years, and the utilization of Feldman criteria, which is well understood in this particular literature, as in our expert case reviews, allows us to identify those cases that we include in analyses of trends and patterns and whether they're associated with any external changes, for example, the pandemic policies. Now, of course, the limitations are that we have extremely low case numbers, which make it difficult for analyses. And there may be a further limitation in the case of COVID-19, that there may be some underestimation of cases that may have not have been reported or have come to the attention of police or child protection services because of the closure of services and community centers and childcare centers, which would act as normal centuries for reporting this kind of incidents if it were noted. And so with that, I'll pass it back to Sarah and ask her to sort of make the summary of our findings for the overall study.
Thank you so much. So some key findings from this project include some understanding around, or a better understanding around health administrative data. And our data agrees with the scientific literature in this case, where we have demonstrated decreases in the number of cases that were reported during the pandemic compared to previous to the pandemic. However, when we look at other data sources, we can see some increases, and particularly looking at the CHIRP data, increases in Ontario of reported sexual assault cases. It appears there was a change during the pandemic in the types of maltreatment that children and youth were experiencing, as well as the setting in which these incidents took place, as well as who the perpetrator was, comparing these data to previous to the pandemic. However, we're still unsure of the change when we look at specific inflicted violence injury cases, of course, those highlighted by Dr. Pike with traumatic head injury. And these require further investigation, as well as other specific inflicted violence injury mechanisms. This work demonstrates that there might have been some indirect effects of stay-at-home policies on inflicted violence injuries in Ontario and British Columbia, and should be used, or this information that we've generated, as sort of part of a process to inform future emergency response policies. We highlight a gap in the preventative measures as well as the support systems that are in place for children and youth during stay-at-home policies, and highlight that there is a need for increased awareness as well as targeted interventions to address these increased risk situations. Future work in this area are sort of divided here by province, although we're still working together on these data. But in Ontario, we have been partnering with many public health units across the province to support integrating the results of this work into their program planning. We know that a lot of the public health units are working with their municipalities to integrate violence prevention and violence prevention frameworks into their community safety plans. And we are lucky to keep working with these public health units in the successful LDCP, where it's dedicated funding to look at a violence prevention framework or implement a violence prevention framework into community safety plans across Ontario. We also seek other data sources, or continue to seek other data sources, and that includes scan data. So here in Ontario, we're looking to access the suspected child abuse network data from the Hospital for Sick Children to try to better understand, again, the context of these injuries, potentially the referral of these injuries, and where these injuries are coming from or being reported to in trauma centers in Ontario. And I'll hand it over to Dr. Pike to discuss the future work for inflicted violence in British Columbia.
Thank you, Sarah. Well, in British Columbia, the BC Injury Research and Prevention Unit, in partnership with health authorities, in particular the BC CDC, has a mandate to monitor trends and patterns of injury in British Columbia, including inflicted violence-related injuries, and to make recommendations to both government and to health authorities on policy and practice. And so that mandate continues. And this work has, I think, despite the lack of differences, pre-pandemic, post-pandemic, and nothing that we can link succinctly to the introduction of policies, I think it provides us, the whole thinking around the study has provided us with valuable information on where we need to be going in the future with respect to frameworks that could be developed and implemented so that community preparation for future pandemics or disasters where similar policies may be implemented. These represent opportunities, I think, to expand that thinking and to get upstream and not wait for the next pandemic, but to try and have frameworks in place that could mitigate these injuries. I mean, the data did show some small shifts from inflicted injuries occurring in various settings to the home, and a shift from various people to more intimate or nuclear family members. Those are important understandings, even if there were not statistically significant findings associated. And I think these kinds of data help us understand what we can be doing in primary prevention in the future. The second thing is that we have a universal prevention program in British Columbia that's delivered to all new parents called the Period of Purple Crying. It is specifically aimed at preventing traumatic head injury from child maltreatment. And the continuation of this surveillance system helps us evaluate and refine the implementation and ongoing implementation of that program. And so that remains on our agenda to do as well.
So I just wanted to conclude this presentation by thanking the entire CIHR project team, as well as obviously our CIHR funding. I want to thank all of our colleagues at Public Health Ontario, University of British Columbia, and York University in their help and assistance with this work. Of course, to thank the Public Health Agency of Canada for access to the CHIRP data, and BC Children's Hospital for access to Child Protective Services data. Thank you so much.
Okay, thank you, Dr. Richmond and Pike. Congratulations on these wonderful analyses. You seem to have covered this from a lot of different angles, looking at different approaches. So a quick reminder, we're running a little tight on time, but if you haven't already, please enter your questions in the Q&A pod. I do have a couple questions for you waiting, so we'll move on to those. So the first question is, for the psychological and sexual abuse cases, the commenter was wondering if you had an opportunity to look at virtual spaces as sites of violence.
This is a great question. We did not have the opportunity to look at virtual spaces as sites of violence, but certainly hearing anecdotally that, particularly looking at peer-to-peer violence cases, that these virtual spaces sort of increase access to violence-related incidents. We certainly acknowledge that that is a limitation of this work and have considered that as part of the future work in this area.
Okay, thank you. A second question, and this is something I was wondering about as well. So in March 2020, the commenter said they think that in Ontario had an immediate decrease in ED visits and hospitalization visits for any reason, so not just the inflicted injury or violence. They were wondering whether BC had similar post-pandemic decreases in all visits. So if not, maybe this helps explain why BC didn't have the biggest drop. The big drop in inflicted violence. So I guess like one of the interesting parts about your finding is really this like cross-provincial comparison and one finding in Ontario and maybe not as much in BC. So Does that relate to the overall system? And did you see a similar decline in ED visits or hospitalization visits?
Well, curiously, we have a parallel project which is examining unintentional injuries for the same sort of period, utilizing the same type of analyses. In fact, we do see a decrease in the number of unintentional injuries, in particular road-related injuries. That would be expected, I would imagine. Cars were, people were told to stay at home, cars were off the road, and so those injuries go down. Similarly, recreation and play space related injuries went down. So the answer is we did see those reductions in other kinds of visits, driven, I think, from a real reduction in the number of injuries, as according to the types I've just mentioned, but also, as Sarah mentioned, from the fear of attending a medical facility where COVID was present. And so people avoided attending health centers, I think. Why we do not see the similar reduction in inflicted violent related injuries, we're still trying to figure that one out. We have no explanation at this time, and welcome people's input if they can think of why it might be.
Okay, thank you. That's a really interesting answer, and a very tricky thing to look into. So another question was just about, I guess, your approach to the whole project. So that, again, that comprehensiveness of it. So during the pandemic, there's across a number of key areas, like many of the researchers in public health units will notice that we had a real challenge accessing quality data. And this was like in your first analysis, this was kind of indicated that enhanced data collection methods during the pandemic, during the public health emergency occurred. So I wondered about whether there are opportunities, what have we learned through your project and your comprehensive approach, and are there any potentials for improving that going into the next pandemic?
That's a great question. I think that the greatest thing that we've gleaned from this project is that we need to create mechanisms in which children and youth themselves can access a reporting system for these types of injuries. We know from the literature that typically daycares and schools are settings in which these cases are detected. And particularly during public health emergencies like COVID-19, these settings were shut down. And there was an inability for us to detect cases of inflicted violence in children and youth, and then refer those cases to Child Protective Services. And so the greatest thing that we've gleaned, and if there was one key message from particularly around data and what we've learned from the data, is that we need to create mechanisms, potentially virtual mechanisms, that allow our children and youth themselves to access not only the ability to report, but the ability to access services to address these very serious injuries.
Indeed. Yep.
Okay, great. And I think you covered this well in your closing remarks, Sarah. But one of the things I was wondering is, we started the presentation and there was this anecdotal idea that injuries were increasing quite a bit during the pandemic. And so your research, you had that nice slide where it said, like, depending on which data you look at, it either increased or decreased. But I wondered, is there a simple answer to that? Like, does your research and what you're finding, does it refute that increase in violence in children early in the pandemic?
I don't think we have the data sources that can tell us that story, and we are continuing to seek alternative data sources. And what's really encouraging is the initiatives that are being taken by our ministries in Ontario to decrease these ministerial silos around access to data sources. So if we had the ability to access Child Protective Services data, for example, to better understand the actual number of cases that were being reported, that were potentially reported, increasing access to police services data for us to understand the number of cases that were being reported through that mechanism in Ontario, can certainly help us to better understand the actual number. We truly believe that these cases were underreported. Of course, those cases that were severe enough to actually present to hospital and, of course, be hospitalized were presenting, regardless of the implementation of these policies. But we do believe, particularly for this injury mechanism, that a significant number of cases were missed.
Yeah, no, thank you, Sarah. I would just highlight in British Columbia, I think that we're very fortunate. with our government and CDC in particular, creating platforms of data that is available. And our access to child protection services data for chart review is an example. I would emphasize, though, the important point that Sarah has made about justice-related data from police sources, from other social services, from kids' helplines. If we can systematize those in a better way, I think we would have much greater insights and rather than waiting until somebody presents because they require health information. I think that we could learn much from the reporting and investigations data.
Violence prevention has become a very important topic to public health units in Ontario, particularly because Ontario has declared intimate partner violence as an epidemic. Mm-hmm. And as we know, intimate partner violence as exposure to family violence in children and youth is a very significant adverse childhood experience. And so I know of a lot of public health units working together and with Public Health Ontario to increase local data collection efforts, particularly around ACEs, but really highlighting the need for work in this area and really leveraging opportunities like declaring intimate partner violence as an epidemic, as an opportunity to investigate this further.
Mm-hmm.
Okay, thank you very much. I think that's a good place to leave it. I know we're a couple minutes over, so thanks to everyone for hanging with us. As we conclude today's PHO rounds, I'd like to thank both Dr. Sarah Richmond and Ian Pike for their really in-depth analysis, again, of this important issue, and extend my appreciation to everyone who joined us for today's webinar. A reminder to everyone to save the date for topic, which will be held on March 26th and April 2nd in 2025. So thank you very much, everyone, and have a wonderful day.